Okay.
Good morning, ladies and gentlemen. It's a great honor to co-chair with Professor Kitas. Good morning, Professor.
Good
Professor
morning.
Katsifis. Good morning. And we are ready to start.
Okay, good morning from me. I'm Dr. Katsifis. I'm a rheumatologist. Since it's the time for rheumatologists to speak, I'm Director and Chief of the Rheumatology Clinic at the Naval Hospital of Athens. So, Professor Ageli, can we start with the first speaker?
Of course. So we start with Professor Kitas. We proceed to a pre-recorded talk presentation, Atherosclerosis in autoimmune rheumatic diseases. A very interesting cases, a very hot topic, and we proceed to the talk.
Good morning, and thank you very much for inviting me to talk about atherosclerosis in systemic chronic inflammatory autoimmune conditions, the main one of which is rheumatoid arthritis. I do not have any conflicts of interest for this lecture. What I'm going to talk about in the next half an hour or so is outline what the problem is, what is the nature of the problem, concentrating on atherosclerosis, and then mention what are the implications of current knowledge for patient management. So, what is the problem? Well, the problem is that cardiovascular mortality in people with rheumatoid arthritis, and indeed in people with most other chronic inflammatory rheumatic conditions, is elevated by about 50% compared with the general population. And there are multiple studies that have demonstrated this over the last 2 decades, and the problem is that it does not appear to be improving at all. And the same, in fact, applies to cardiovascular morbidity. Whatever we're looking for, whether it is ischemic heart disease, atherosclerotic ischemic heart disease, whether it is congestive heart failure, peripheral vascular disease, cerebrovascular disease, it is again increased not only in rheumatoid arthritis, but in psoriatic arthritis, ankylosing spondylitis, lupus, and many other chronic autoimmune conditions. So, why does this happen? What is the nature of this problem? What can explain this increased cardiovascular morbidity and mortality? Well, before we go on to discuss specifically atherosclerosis, I would like to try and classify things in different boxes, because at least in the cardiovascular literature, in rheumatoid arthritis and other rheumatic conditions, we put everything in one basket, but it's not necessarily the same. So when we discuss this field, we may be talking about causes which in themselves may be diseases, for example, hypertension, dyslipidemia, obesity, insulin resistance, inflammation per se. We may be talking about processes, atherothrombosis, atherosclerosis, vasculitis, microvascular dysfunction, myocarditis, and many others. We may be talking about the pathophysiological effect of these processes, which for the purposes of today are predominantly myocardial ischemia and dysfunction. We may be talking about the clinical presentation of these effects, which could range from absolute normality to well-recognized symptoms such as angina and syndromes such as a heart attack, heart failure, arrhythmias. Or we may be talking about the outcomes of all of this, which again can range from normality to cardiac disability and death. And we've got to separate these things so that we understand the basic mechanisms and we can address them one by one and improve the outcome of our patients. So, what is the nature of this problem? We will talk today more about atherosclerosis. So, what is the evidence for accelerated atherosclerosis in rheumatoid arthritis and other systemic chronic inflammatory conditions? Well, the first piece of evidence comes from the theory, the role of inflammation, which, as we now know for at least 30 years, is involved in the process of atherosclerosis, and in fact, it's very similar to what we rheumatologists have been saying in the rheumatoid joint also for decades. We have roughly the same type of cells involved, we have roughly the same types of cytokines involved, we have roughly the same types of free radicals, proteolytic enzymes, etc. that can cause tissue damage. So there is pretty good, strong theoretical basis why in chronic inflammatory conditions vascular inflammation may accelerate. And this is born also from the epidemiological studies which show that the more systemic inflammation one has, measured by the CRP, for example, the more likely it is to suffer a heart attack, both in the general population and in people with rheumatoid arthritis. So, the effect of inflammation could be either direct effects on the vasculature or through effects of inflammation on the so-called classical cardiovascular risk factors, which then downstream can affect the vasculature and lead to atherosclerosis. And we may be talking about low-grade inflammation, such as that we see in people with diabetes and the metabolic syndrome, high-grade inflammation, such as that we see in people with rheumatoid arthritis, and we can then discuss other mechanisms which may be more relevant to other conditions, such as systemic lupus erythematosus. Then we have multiple vascular function and morphology studies and biomarkers which suggest that subclinical atherosclerosis is elevated in people with rheumatoid arthritis, and we and others have indeed assessed in a non-invasive way the whole vascular tree. I'm not going to discuss these studies one by one in detail because there are literally many hundreds of them, but effectively what they tell us jointly is that subclinical atherosclerosis appears to be more pronounced in rheumatoid arthritis compared to controls, and it's equal to people with type 2 diabetes. The changes in microvascular and macrovascular endothelial function appear to be independent of each other, and both classical cardiovascular risk factors and inflammation play a role, but they appear to have different effects on vascular smooth muscle cells and endothelial cells. Generally, in these studies, classical cardiovascular risk factors appear to have a greater impact than systemic inflammation on the various vascular parameters. The third piece of evidence for accelerated atherosclerosis is again from epidemiology, where rheumatoid arthritis behaves in a similar way to type 2 diabetes. As you can see here, the cardiovascular comorbidity in people with rheumatoid arthritis virtually shadows this of diabetics, and it is increased. And again, everybody accepts nowadays that diabetes is a CHD equivalent. And then the next piece of evidence is that in people with rheumatoid arthritis, we have an abundance of classical and novel risk factors, including hypertension, dyslipidemia, obesity, physical inactivity, and several other factors, and we will discuss them briefly. So then, we have The non-modifiable classical cardiovascular risk factors, such as age, sex, family history, that we can do nothing about. And specifically in people with autoimmune conditions, we also have some other not modifiable risk factors, such as, for example, the presence of specific autoantibodies, like rheumatoid factors and ACPAs, disease duration, etc. But in the middle, we have multiple so-called modifiable risk factors that we can do something about, like lipids, blood pressure, insulin sensitivity, physical activity, smoking, obesity. And specifically in our patients, we need also to consider inflammation and the therapy we use to control it as potentially modifiable risk factors. And we and others have researched each of these risk factors separately. I'm not going again to discuss each of them in detail, but we have mechanisms, for example, by which hypertension could be explained to be increased in people with rheumatoid arthritis. And generally, again, what we can say is that classical risk factors such as hypertension is highly prevalent, underdiagnosed, and undertreated in our patients. It associates with older age, long-term steroid use, obesity, and increased uric acid. And organ damage from hypertension is relatively common, and the result is really that we need aggressive identification and treatment strategies for hypertension and its modification in these people. Effectively, the same happens with lipids. Again, I'm not going to discuss in detail the effects of inflammation on lipids, but dyslipidemia is, like hypertension, again highly prevalent and undertreated. There are many proatherogenic changes in lipid levels, structure, and function, which appear to be reduced with successful anti-inflammatory therapy. Systemic inflammation, drug therapy, and some genetic factors appear to be contributing to it. And we definitely need to do more studies to assess the relationship between lipid metabolism and systemic inflammation, because this appears to be a bidirectional effect. Same applies to body composition. People with rheumatoid arthritis and other chronic inflammatory conditions develop a situation called rheumatoid cachexia. What is this? The bottom line is that it is loss of lean body mass, of muscle, which is replaced with fat. And this can have obviously many adverse downstream implications. The causes of rheumatoid cachexia are multiple, but the main two are the effects of inflammation on muscle and the effects of the physical difficulties that these conditions cause on mobility. And putting the two together, there is quite a lot of muscle wasting in these people. And on top of that, we know that physical inactivity associates clearly with several cardiovascular risk factors, including, again, hypertension, dyslipidemia, insulin resistance. And we also know that by applying, and we've done these studies, that by applying systematic personalized exercise programs in these people, we can, to a large extent, reverse these adverse effects. So then, again, to summarize all of this field, is that inflammation and lifestyle, particularly diet and physical activity, play a significant role in body composition alterations in these people. Obesity is very common and associates with cardiovascular risk factors and response to treatment. And management of body composition needs to be included in our overall therapeutic approach in these people. And then, on top of that, we have multiple other factors, for example, drugs, smoking, seropositivity, etc., that we need to take into account. And again, I will concentrate on modifiable factors, the main one of which is the treatments that we use to control inflammation in our patients. And we know that virtually all of the drugs we are using can cause some vascularly related alterations. For example, non-steroidals and coxibs can cause hypertension. Hydroxychloroquine appears to have good effects on lipids. Methotrexate, on the one hand, appears to relate to less metabolic syndrome, but on the other hand, if it is not opposed with folic acid, may cause hyperhomocystinemia. Steroids are well known for their effects on hypertension, dyslipidemia, insulin resistance, whereas the multiple biologic and targeted synthetic disease-modifying drugs do have very well-known effects on lipids, blood pressure, body composition, and some of them may be apparently negative, some of them may be apparently positive effects. And then, epidemiologically, we appear to have multiple interactions between classical and novel, so-called novel risk factors. For example, smoking, which is a classical risk factor for cardiovascular disease, does associate with seropositivity for rheumatoid factor and citrullinated peptide antibodies, does associate with the presence of rheumatoid nodules, with increased disability, with less response to some biologic agents, with increased metabolic rate, which could contribute to rheumatoid cachexia, and all of these are risk factors for cardiovascular disease in people with rheumatoid arthritis. But are they because they smoke? Are they independent of smoking? These are difficult questions to address and to answer in a definitive manner. So assessing attribution in these patients is quite difficult. But the bottom line is that all of these pieces of evidence clearly suggest, in fact demonstrate, that accelerated atherosclerosis is one of the main problems that contribute to the increased cardiovascular morbidity and mortality of these patients. However, we should not forget that it's not only atherosclerosis, there are other mechanisms which I will just mention because today I was asked to talk only about atherosclerosis. One of them, of course, is plaque instability, and we have a lot of evidence that atherosclerotic plaques are more unstable in people with rheumatoid arthritis. There is a higher infarction rate. There is evidence from 64 slide CT angiograms. There is evidence from gene microarray studies using carotid plaques. There is evidence from autopsy studies. There is strong evidence for derangement of hemostasis related to inflammation in these patients, all of which suggest that plaque instability is a serious problem that we also need to address. And there are, of course, other mechanisms. I'm not going to discuss them in detail. One is microvascular disease, and the other is cardiac autonomic dysfunction, which may associate with sudden death in these patients. I'm not going to discuss this. So then, what are the implications for patient management? Well, the first thing that we've got to do as a clinical community is to monitor individual risk factors. For example, blood pressure in all of these patients. We and others have produced evidence over 15 years which suggests that this, although it's known, it's not changing in routine clinical practice, that about 2/3, 70% of all rheumatoid patients attending secondary care are hypertensive. Of those with hypertension, 40% remain undiagnosed, and even of those who are diagnosed, 80%, 4 in 5, are suboptimally controlled. It's not surprising that these people are not doing as well from the cardiovascular perspective as the general population, and exactly the same numbers almost apply to other risk factors like dyslipidemia. Once we have assessed them for these risk factors, we can use a composite cardiovascular risk score algorithm. There are many. I'm not going to discuss the merits or not of each one of them, but it may be necessary to apply a multiplier which reflects the 50% increase of cardiovascular risk in these people. In fact, some of the new algorithms include this already. Once then we have decided whether they need to alter something to reduce their cardiovascular risk profile, we have two main instruments to address this. One is drugs and the other is lifestyle modification. And I will spend a little bit more on lifestyle modification than pharmacological therapy, because in lifestyle modification we do virtually nothing, whereas drugs we know pretty well. So we have demonstrated that educational and cognitive behavioral interventions can actually reduce specific cardiovascular risk factors in people with rheumatoid arthritis by making them be more careful with their diet, with their physical activity, etc. We have converted some of these into internet-delivered interventions and again demonstrated that they can have an effect. Smoking cessation is important. About 25 to 30% of these people still smoke, and this has adverse effects not only on their cardiovascular system, their risk for cancer, etc., but on their arthritis per se. We have demonstrated that personalized exercise delivered by specialist exercise physiologists does have a significant positive effect in individual cardiovascular risk factors and their composite risk, and in some cases even their longer-term outcome, although these studies are of course very, very difficult to perform. And there is evidence that a Mediterranean diet, I would probably say more a Mediterranean lifestyle, also appears to have a beneficial effect. So there is quite a lot that we can do for these people with lifestyle modification, but it is something that we are not spending enough time and resource towards. And then, of course, we have medications. On the one side, we have the anti-rheumatic medications, and it is extremely important to try to control the inflammation as effectively as possible in these people, because there is absolutely no doubt any longer that this is an important way, on the one hand, to improve their rheumatological outcomes, but on the other hand, to improve their cardiovascular outcomes. Having said that, however, we need to be careful and considerate in choosing and handling these anti-rheumatic medications appropriately. For example, it does not make any sense to use some anti-rheumatic medications that cause hypertension in a patient who already has hypertension when we have an awful lot of other alternatives we could use. On the other side, we have all of these therapies that we can use to address individual risk factors like antihypertensive agents, lipid-lowering agents, glycemic control, and now, of course, we have agents that may help with weight control. There, the main issue that we need to resolve is who manages this, because rheumatologists cannot have the required expertise for all of these agents. Cardiologists probably do not know enough about the rheumatological side of things. In places where there is a primary care system working, GPs do not have time to do anything. So we do have quite a lot of system issues to resolve about what is the best way to address these risk factors. And I would like to add with what does all of this mean for us as clinicians? Well, the first thing is that we should look at the individual patient, not their disease. 100 people with rheumatoid arthritis, they all have rheumatoid arthritis, but none of them is exactly the same with the other one. We need to be aware of comorbidities and their significance, and today we talked about cardiovascular comorbidity mainly, but there are other comorbidities that are almost as important. We need to develop strategies to assess both the primary disease and the comorbidities. So we rheumatologists could, for example, measure people's blood pressure at each visit. We could request lipid measurements, glucose measurements every now and then if treatment is needed, we should communicate with other specialties and implement the treatments. We should consider all therapeutic options very carefully for a given patient, and we should treat to target in the same way that we have clear targets, which in many cases we achieve for controlling inflammation. We should have clear targets that we should aim to achieve for blood pressure, for lipid control, etc. In order to achieve this, it's not sufficient just to give people medications. We need to inform them and make them partner in their management. And to be good rheumatologists, we need to be excellent physicians. In fact, I think to be good specialists in any specialty, we need to be excellent physicians. I would like to thank the many people that have helped do this work over the last couple of decades, and also the funding bodies. And thank you very much indeed for giving me the opportunity to talk to you today. Thank you.
Okay, it was a very interesting lecture. Unfortunately, we do not have Professor Kitas with us to answer the questions. Anyway, I will summarize what he has just told us. Accelerated atherosclerosis is a fact in inflammatory diseases, especially rheumatoid arthritis, as he noticed, beyond plaque instability. We should not also forget the microvascular disease, as he mentioned, especially since we have now CMR that can help us to diagnose patients with microvascular disease and heart inflammation, and so and then implement the correct anti-inflammatory rheumatic therapy. He mentioned and stressed that lifestyle modification is very important for the patients with rheumatic diseases, such as using regularly exercise and applying diet, especially Mediterranean diet, and as far as concerning the therapy. He stressed that we should apply the correct anti-rheumatic therapy with the right anti-rheumatic drugs, those that are compatible with each patient, personalized medicine for each patient, beyond addressing the traditional risk factors such as dealing and treating hypertension, hyperlipidemia, and keeping the sugar levels, the sugar at normal level. He finally said and stressed that each patient is unique. We need to apply personalized medicine for each one of our patients. Do not forget the comorbidities, as we mentioned. When a rheumatologist and a cardiologist sees a patient with rheumatic disease, and especially rheumatoid arthritis, should check the blood pressure, should check the lipids, should check the weight, and then do the proper examination such as ECG, ultrasound, and even CMR for the patients that we hypothesize that there is microvascular injury. Again, and then this is the big question for us: which patients should we screen for CMR? Since we are in a CMR meeting, should we screen all the patients, even those with low inflammation, or should we screen the patients that already have some problems in the ultrasounds, having some arrhythmia or hypertension that we cannot control? So I think that these will be the topics and the questions that will be elucidated in the next sessions. Now I see that